Thank you for bringing me here to talk. I have no disclosures, and again, this is really a massive topic, so I'm going to try and cover it all with just a few illustrative cases of metastatic colon and rectal cancer, just to kind of review some of the indications for surgery, how we choose these patients, who we're operating on, when we're operating on them, particularly with synchronous disease, how we use chemotherapy, and how we're increasing our use of ablation in unresectable cases to kind of expand the patient cohort with which we offer surgical treatments. This is ultimately something that affects up to 50% of people that present with a colon cancer at some point in their treatment course, and currently only about 15% actually undergo resection for the disease. So ablation, which I'll talk about later, helps us kind of expand that pool and improve our outcomes. So we'll start with a 62-year-old male with metachronous metastases from a colon cancer that was treated with adjuvant K-pox. The primary was node positive. You can see here a large tumor in the left lobe of the liver. You don't catch it well here, but there's multiple satellite lesions. There's been a year or more of disease-free interval, and we have an elevated CEA. So the question in today's world is, how do we proceed with this? And the answer is resection, but for this patient, that may not have always been the case. Resection has long been standard of care for colorectal liver metastases, but you have to remember most of these early studies that I show you here were done in patients with oligometastatic disease, so relatively low disease burden in the liver. With R0 resection, you can see excellent 5-year survivals of 30 to 60%, depending on the study that you look at. In a lot of these studies, the reason they included patients with relatively lower disease burden is they were uncovering multiple prognostic factors that showed worse, or that were associated with worse outcomes. A lot of the things our patient has. Large size of metastasis, they have an elevated CEA, the primary tumor is node positive, there's a large number of metastases, and these things were largely the basis for the traditional contraindications to remove liver metastases. 4 metastases, extrahepatic disease, inability to obtain negative margins, and patients that weren't medically fit to undergo the operation either because of their liver reserve or because of their medical problems. So traditionally, you can see our patient pre-2005 may not have been a resection candidate, but a lot of people have done studies since then, including more extensive liver burden, sometimes even extrahepatic disease in either the peritoneal cavity or the lung, and continue to show excellent 5-year survival rates and median survival durations with resection of this metastatic disease. Now, mind you, all of these are retrospective studies. None of them are randomized trials. None of them are directly compared to chemotherapy alone. This is just compared to historic controls, so we do have to remember that. But naturally, over time, as we've offered resection to increasing numbers of patients, we're realizing the importance of preserving liver parenchyma because a lot of these patients are going to recur in the liver, they're going to need further liver-directed therapies, and we're doing more and more and more chemotherapy all the time, which has an effect on liver toxicity. So this just shows you a systematic review from a couple of years ago that shows no difference in morbidity, mortality, or survival when you compare a parenchymal-sparing resection versus an anatomic resection. So today, the people that we're offering resection to are really those that aren't biologically progressing. We're offering surgery to those who can tolerate it, and we're offering surgery in cases where the liver that's left over is actually enough for them to live on. And then we prefer parenchyma-sparing techniques whenever possible. So we know our patient's going to get a resection. The next question you can quickly ask is, what role does chemotherapy play and when do you give it? Some people think you don't need to give any chemotherapy for resectable liver disease because the biggest effect on survival is the resection. So do you give it at all? Do you give it adjuvantly? Do you give it neoadjuvantly? And I think we've all seen with the paradigms with primary tumors, everybody's leaning more towards that neoadjuvant approach. But there are pros and cons to all of the approaches. Adjuvant therapy is going to allow you to treat the disease right away and avoid that liver toxicity, but at the cost of having less pathologic response and more often progression of metastatic disease elsewhere in the liver. I'll lump together the perioperative and total neoadjuvant approaches because they both increase compliance with chemotherapy. They allow you to assess tumor biology and response. And as we've seen with primary tumors, they often allow downstaging of borderline resectable patients to a resectable state. The problem is if you have a lot of small lesions, you can sometimes have those disappear during therapy and they're difficult to find during surgery. And with increasing number of cycles of chemotherapy that you give, you get increasing liver toxicity that can limit your resection. Nobody's ever showed any difference in overall survival between any of these approaches. There has been progression-free survival benefit demonstrated in a phase 3 randomized trial for perioperative therapy in resectable liver mets. And you team that with the ability to assess response, to downstage, and to assess biology of the tumor. Most people favor a neoadjuvant approach of some type whenever we see colorectal liver metastases, whether they're metachronous or synchronous. And this is important to liver surgeons because increasingly we're seeing a lot of patients that get a lot more chemotherapy up front in our clinics. And this is associated with oxaliplatin-containing regimens with sinusoidal obstruction and with irinotecan-containing regimens with steatohepatitis, both of which, but particularly the steatohepatitis, increase post-liver resection liver failure rates. So it's very important to consider the timing and duration of these therapies before surgeries so that you don't limit your resections for your patients. Our patient, unfortunately, got a lot of chemo. They got their adjuvant K-pox. When he recurred, he had 6 cycles of FOLFIRI-Avastin and progressed. Went back to the tried and true FOLFOX with stable disease, but then his FLR was massive. He had 75% of his liver because most of the left liver was taken up by tumor, and he was able to have R0 resection with a left hepatectomy. Data will show that he's likely to have a good long-term outcome, but he's going to have a 50, 60, 70% recurrence rate within the liver. And it turns out that even with a recurrence, there's still a role for re-resection in selected cases. This is just an old study. There's been many since, but I think this paper really looked at it well. Patients that get a resection for their first recurrence, R0, still have 10-year survival rates that can approach 20, 30%. The thing that this paper also shows you is that as the complexity of the recurrence increases, either many lesions or large size of lesions, you get incrementally less benefit from your resection. So we always consider a re-resection of a recurrence, but it's really important to pay attention to biology too when they recur, because that's ultimately going to be the king of the outcome. So just to shift gears a little bit and talk about another controversy within the field is, what do you do with a resectable synchronous case? So this patient had a resectable synchronous isolated liver metastasis and a primary colon cancer. The question becomes, do you take the colon out first, do you take the liver out first, or do you do them both at once? And again, just like with the chemotherapy arguments, there's pros and cons to all of these. You're going to treat the primary first, prevent complications of bleeding and obstruction, and maybe allow a time test when you address the primary first. All of this at the risk of progression of disease. Liver first approach is going to treat the most significant survival predictor, but if you're not using a perioperative approach, it can significantly delay systemic therapy, and you can develop complications from your primary tumor during that time. So it becomes attractive to think of synchronous resection because it allows treatment of all of that disease in a single operation. Some think it's more technically difficult and might be risk prohibitive, but I'll show you some data that sort of contradict that in just a second. None of these really show any difference in overall survival. So the question becomes, how do we choose? How do I choose? This is just a retrospective study from the University of Minnesota in 2013 that compares staged resection with combined resection in patients with synchronous disease and shows no difference in length of stay complications or mortality between the two, unless your patient has significant frailty with an Elixhauser score that's high, or unless the patient has a surgery that's combined with a major hepatectomy. So definitely feasible. Tim Pollack's group at Johns Hopkins subsequently showed there's no difference in morbidity, mortality, or survival when you compare SAGE to synchronous resections. And then he did a follow-up study at Ohio State in 2018 that showed that it's probably more cost-effective, obviously, to do a single operation than 2 operations. And just practically, when you're in clinic, if you present these to your patients, none of them are ever going to tell you they want 2 operations instead of 1. Because of that, If it's possible, I personally favor synchronous resection over a staged approach. I like liver-first approaches when there's either going to be a major hepatectomy or when you need significant preoperative chemotherapy to downstage a person with significant liver burden. So in this era where we're doing more and more synchronous resections, I think we've already heard about this in previous talks. It's very much the same. A lot of the paradigms are shifting towards doing more total neoadjuvant approaches. So there's a lot of ways you can address your systemic therapy and your local therapy preoperatively. This is just one. You can do your classic radiation followed by your consolidation chemotherapy. That can range from 2 to 6 cycles depending on the study that you look at. You, in a primary that doesn't need the chemoradiation, you can omit that and just do the FOLFOX. You can substitute short course radiation. There's a lot of ways you can do this, but they all turn out to end up having pretty good outcomes for patients that are getting synchronous resections. So just to switch gears slightly, I want to talk a little bit about patients that are unresectable, because like I said, there's a lot of people that don't get surgery for their colorectal liver metastases. And more people are publishing data on ablation, particularly in combination with surgery, and still showing excellent outcomes. The problem is a lot of these people are publishing on percutaneous ablation and surgery, kind of 2 separate sessions. So I'm just going to give you an example. This is a patient that was treated a couple of years ago before I was here. T3 rectal cancer and unresectable bilobar liver metastases that had an excellent response to neoadjuvant therapy. And she was taken to the OR for a laparoscopic LAR, combined ultrasound-guided microwave ablation of 7 tumors, and partial resection of 2 more. She went home quickly, and we can say that was sort of a surgical win. But the question is what's the survival going to be when we cherry-pick tumors out of the liver? Does it really work? Is it better than chemotherapy alone? And this is just our experience that we haven't published yet. It's in preparation, but it's 40 patients that we've done surgical ablations on, either in combination with resection for a primary or with partial resection of the liver, most of these done laparoscopically. And what we've shown is that ablation lesion recurrence rates way at the bottom, that little red circle, you can see the per lesion recurrence rate is pretty low. It's about 4%. Resection rate recurrence is probably around 2%, so it's not much worse than resection. And you can see the intrahepatic recurrence rate of 28%, this is sites separate from where you ablated, is actually comparable to resection and better than many published series. And the systemic recurrence rate, of course, is no different. So what we see in patients that we successfully ablate, whether it's with or without resection, if they don't have a recurrence, they still have excellent median survivals, long-term survivals. Of course, with recurrence, that median drops off, and we're looking at more the 32-month range. This randomized phase 2 trial that was done just a couple of years ago actually compared patients with unresectable liver metastases who got chemotherapy alone or got chemotherapy plus ablation plus or minus surgery. And what it showed in this population of 119 patients is that 5-year survival with aggressive liver-directed therapy was about 45% versus 30% in patients that got chemotherapy alone. So even though it seems like a lot, you really can have time to gain for these patients by treating liver disease aggressively, obviously in appropriate selected patients that are going to tolerate this. So just to summarize, I will say that in patients that aren't biologically progressing, in which you can leave enough liver behind and they're going to tolerate the surgery, surgical resection really should be our standard of care whenever we see colorectal liver metastases. I think thinking about the role that chemotherapy plays up front is very important, and one of the reasons that I think we need to get people to liver surgeons early, because if you're getting too much upfront therapy, it's going to affect your resection. When you have synchronous disease, synchronous treatment is the best whenever possible, I think. The liver-first approach I like to reserve, again, for extensive liver disease with extensive chemotherapy, major hepatectomy, colon-first approaches or rectal-first approaches with complicated primaries that bleed or obstruct, or in very frail individuals. And again, I can't stress the importance that even in cases where you think a patient's probably not salvageable surgically, many times there's still options for aggressive liver-directed combo therapies that can improve survival over palliative chemotherapy alone. So with that, I just thank you for allowing me to talk again.